Yes, my children were most entertained when I got the Clot of the Year award. Dubious honour. So it's a real pleasure to be here tonight. I love the opportunity to talk to people and share ideas. And I also want today to introduce some other members of my team that are here. At the back, there's Amanda, who's a nurse who's an expert in clotting. Amanda, you can raise your hand. So she's the clotting side. And there's Jackie, who's an expert in the bleeding side. And if you want any intelligent computer questions, you can always ask Asha, who's in business intelligence at the front.
No, we should have asked her that question.
So if you believed everything in the newspapers, you would think that the NHS is in freefall. And many of you might find it quite hard to reconcile that with your personal experience, because what I find when I talk to people day by day is that they, or their friends, or their family, have been into hospital and really experienced high quality care. Now, I'm not saying that this is perfect care, because at the end of the day, the NHS is run by human beings and we're not perfect. We do our best, but every now and then we make mistakes. But in reality, the NHS in this day and age is better than it has ever been before. And it can be even better, but it needs to be better with your help. Gone are the days of the James Robertson Justice when the doctor stood up the front and said, "This is what you will do," and then walked away from the bed, leaving you in pieces. Nowadays, it's more about partnership, sharing an understanding of the risks, and taking it forward together into the future. And that is why this is the title of my talk. Now, I'm a blood doctor. I went into medicine a very scary number of years ago, and then got diverted into blood medicine because it's very exciting. Blood medicine is where the science of medicine is really being translated into real benefits for patients. And I'm going to talk today a little bit about the basics of blood science, and hopefully, through giving you a small understanding, help you to see how you can help yourselves, and then take that message away, share it with your friends and family, and hopefully we can improve the whole health of the nation today. So,
Small ambition.
small ambition, one step at a time. So, if you take a sample of blood out of somebody's body and leave it to stand, it'll form a great big clot. But in fact, when you've had a blood test, you'll notice that they take it into these little plastic tubes. And the little plastic tubes have actually got something in it. They've got an anticoagulant in it, which stops it from forming a great big lump of sludge. Now, if you take that tube of blood and then leave it to stand, it will separate out. The blood cells will go to the bottom, and the plasma will stay at the top, because the cells are heavier than the plasma. Okay, so plasma is mostly water. And that's my first message tonight, is that your body is mostly water. Without water, you cannot survive. And how many times do I sit in clinic and people say to me, "Oh, but I don't like the taste of water, so I can't possibly drink it." You'd be amazed. People these days drink lots of coffee and tea and not enough water. We need water to maintain our plasma. So plasma is mostly water, but it also contains a lot of clotting proteins, which we call factors, which help our blood to do the right thing, because sometimes we need to bleed and sometimes we need to clot, and that process needs to move round in a circle. Haematology is brilliant. You can take a little drop of blood, put it on a glass slide, spread it, dry it, put special stains on it, and then look down a microscope. And that way I can look straight into your body and see what's going on in your blood. That's what's so exciting about blood medicine. So that's a little glass slide with a drop of blood on, and shown here is a picture of a sample of your blood with special stains applied. Now, the pinky things are red blood cells. That's what makes up most of your blood cells, and they're what carry oxygen, make you pink, and give you the energy to do the activities you need to do from day to day. If you haven't got enough of those, you're anemic, you're pale, you're tired, and you struggle to do your day-to-day activities. The other types of blood cells are white blood cells, which fight infection. They've got these killer granules in them, which literally march around your body, recognizing foreign material, wrapping around it and dissolving it. So these are your infection fighting cells. And then you've got these little tiny things called platelets. So little scrappy things which scurry around, plugging up little holes wherever you make little holes in your circulation because of damage. So clotting and bleeding is a sort of dynamic process. If you cut your knee, it will bleed, but you need it to stop. So your body will then activate all the clotting processes to turn the system around. So, blood flows around your body in these vessels called arteries and veins. The arteries flow away from the heart, and the veins carry blood back to the heart. Arteries are thick muscular structures which have these thick muscular walls which can get narrowed by cholesterol plaques. Now, arteries get those cholesterol plaques when you have too much fat in your diet, when you smoke, when your blood pressure is high. And what can happen is that those plaques can rupture, platelets can stick onto the ruptured plaque, form a clot, which then blocks the entire vessel. That's how it works in arteries. Now the system in veins is a bit different. Veins are like little bendy straws which don't have a dynamic circulation. They're very dependent on your muscles to pump blood backwards. So you may see people who've got varicose veins in their legs, and you can feel your veins. You can feel the veins. If you drop your hand down, your veins will come out. You can squid your veins. They're very soft structures. They require the muscles to pump the blood back to the heart. So the process of clot formation in the veins is a bit different because it depends on the ability to be mobile and active. So what happens is if one of your arteries get blocked, the red blood cells can't get through, they can't carry the oxygen that's needed to the vital areas, and you can end up with death of tissue in a particular organ. And if that happens in the flow to your head, you can end up with a stroke. If it happens in the flow to your heart, you can end up with a heart attack. If you block a vein, the most common vein to get blocked are these deep veins in your calf, and you get something called a deep venous thrombosis, so a clot in the veins of your leg. Now what can happen is that that clot can then break off, shoot up your circulation through the veins, and get soaked up within the lungs, which are a gigantic sieve. And the clot that gets stuck there can cause what's called a pulmonary embolism. Now together we call this DVT and P, we call this something called venous thromboembolism, or VTE. And that's what I'm most interested in. Now you may also have heard about blood clots forming within the heart. Now what happens normally is that blood flows into the heart and out of the heart. In, squeeze, out. In, squeeze, out. But you may be aware that as we get older, we are much more at risk of developing abnormal rhythms of the heart because the electrical activity within the heart changes. And you may even have heard of something called atrial fibrillation, which is a very common condition that people can have where the heart beats erratically. And what can happen there is that blood flows into the heart, the turbulence generates small clots within the heart, and as the heart contracts, it can then shoot small clots up to the brain and cause a stroke. So if we start thinking about how common this is, do you know anybody, do any of you know anybody who's had a blood clot, a DVT, in their leg? Just put your hand up. A clot in the lungs, or has developed varicose veins, or a leg ulcer? Right, this is a very, very common problem. Now we like to think that MRSA and C. diff are desperately common, but they're just not. This is a really, really common problem. More common than traffic accidents, AIDS, breast cancer, all of those put together. Now we know, and we have known for a long time, that admitting people to hospital is a dangerous thing to do. Being in bed is not very good for you. We know that over half of the people we admit to hospital are going to be sick, they're going to be immobile, and we're going to keep them in a hospital bed, and they're going to wait there because they really don't want to miss the doctors and nurses coming around. They're not going to move very much, they're going to stay there. And therefore we know that because they're immobile, their calf muscles aren't working, they might be a bit dehydrated, their system is activated, they are at risk of forming clots. Now a lot of people say to me, well, if I go on an aeroplane, that's where my clot risk is, you know, I've really got to do something about going on an aeroplane. But in fact, going on an aeroplane only carries a 1 in a million risk of getting a clot. Whereas, if you have your hip replacement done with no protection whatsoever, 70 or 80% of you would get a clot. It's risky. Going into hospital is a risky business. Now, most clots, well, about half of all clots can be prevented with the techniques that we've got available to us at the moment. Not all of them, and that's a very important point. Not all of them. I spent today on the phone to a consultant from another hospital who is very upset because she has to go to a coroner's court tomorrow because one of her patients died of a pulmonary embolism. This lady had been admitted to hospital in a very weakened state, having been found at the bottom of her stairs, very emaciated, very malnourished, covered with bruises. Nobody knew quite what had happened. She came into hospital. They didn't know what the story was. They didn't know whether she bled, what had happened. It took a few days for the story to come out that in fact she had had severe depression and suffered bad self-neglect. She was very weak, and once they'd scanned her entire body, they realised that actually that's what it was all about, malnutrition and self-neglect. Now they did everything they could to prevent the clot with the measures that we currently have, but unfortunately she still died of a blood clot. And I went through the whole story with that doctor and said, you did everything you could. You did. We've gone through everything. You did everything you could, but sometimes you can't win. So what can we do to treat clots? Well, there's lots of tools open to us nowadays, and it depends a bit where the clot is. If the clot forms in your heart, so you get what we call a myocardial infarction, then the first thing that will happen is actually that you'll be given an aspirin tablet. That's the first thing that will happen. But the second thing that might happen is you might get blue lighted into hospital, and they might do this thing where they put a stent. It's very clever. They put a wire up through your groin into your heart and then feed a little metal stent over it and open up the artery inside your heart that's blocked with a stent and get the flow back working again. So that's one way of doing it. The other thing you can do is infuse lots of clot-busting treatment into the system. And that's another way of treating clots. And then you can do ever more clever things. I looked at a new device the other week where you can put a wire in and then put a balloon either side of your clot and then put a wire through the middle which vibrates really, really, really fast and has little holes in it which spill out this clot-busting treatment, and you can dissolve the clot inside the vessel and then suck it out again. Very clever. There's lots of new technology which is really changing how we do things. So that's the treatment, but of course we all know that prevention is much better than cure. What we want to do is not end up in this situation in the first place. So we've known for years that people get clots in hospital, but until about 2005, nobody thought, well, we need to have a systematic process for making sure that every person admitted to hospital has a risk assessment, that they have it explained to them that they are at risk, they're told what they can do to help themselves, and then we do what we can to help them prevent a clot, whatever that might be. It might be pills, it might be injections, it might be wearing these lovely sexy stockings that we put on people. Any one of those things. So that's what we need to be focusing on. It is giving the right preventative treatment. And just this, I've long thought in medicine that we could achieve a lot just by getting the basics right every day. And last year, this body in the UK that's designed to look at our outcomes looked at what we could do if we made sure that more than 90% of people admitted to hospital had a risk assessment. And they found that we could save at least 430 lives per year if we just make the change from 89% to 91%. Small shifts in change really save lives, just by getting the basics right every day. So you might say, well, why 90%? Why 90? Why not 100%? And you're right, it should be 100%. But any of you that have ever been in an emergency department or a medical admissions unit will know that there is a lot going on. It's not as easy as it looks to juggle all the very many issues that are going on for any one individual at the same time, and at the same time think about what's down the road. You've got to think about the Parkinson's, you've got to think about the fact perhaps they've got dementia problems, and then you've got to think about the acute pneumonia that's going on. Then somebody in the next bed, their heart might stop and you've got to move on and deal with that. So we need to be realistic and say, we're going to get to this high target, but I don't think we're going to get to 100%. So we are going for 95%, and I am pleased to tell you that we are above that 95% target regularly this year. So what can you do to help yourselves? Well, I've been playing with NHS Choices, designing a little self-assessment tool. And the NHS Choices website is very good if you haven't been on it. There's lots of information there. And if you go on there and look up VTE, you can do a little self-assessment with pictures, which at the end of the day will tell you whether you're at risk of blood clots or not. And this is really worth doing if you're going into hospital, because then you can come into hospital armed with the information that can help the doctors and nurses give you the right care. Because you'll be going, you know what, I'm a bit worried I might get a blood clot. What can you do to help me? And that will help them deliver the right care for you. We've also produced a whole wealth of other information, some of which I produced a DVD, which you're most welcome to have. I produced it with a drug company on the proviso that I didn't want to get paid for it, but they had to provide it free to anybody that wanted it, so that's available if you want it. The key messages in clot prevention are, if you come into hospital, then think about it, plan it, in the same way as you would before you're going on holiday. You wouldn't go off on holiday without your passport and your money and your suitcase and everything else and your health insurance. So when you come into hospital, plan for it. Think ahead, drink plenty, take plenty of exercise, work with your doctor to make your health as good as it can be. And when you get into hospital, make sure that the doctors and nurses are aware that you think you might be at risk of clots. Because this is what we want to prevent. It's not only death from clots. Sometimes I think death isn't the worst possible outcome. It's living with clots. It's living with what my mother now has to live with, which is this: long-term dependency on oxygen because of recurrent clots in the lungs. It's living with nasty, ulcerated, oozy legs, which have to be dressed on a regular basis because the veins have been so badly damaged that the return is poor and you just keep getting infection in those legs. It's living with having to take medicine on a daily basis which interferes with your quality of life. So you bruise easily, you bleed easily, you have to think about what you need to do, and you have to work with us on taking a bucket full of tablets. So, warfarin. Now, this is a really interesting story, the discovery of warfarin. Warfarin was discovered, warfarin is actually made from clover. So what happened was, this was in Wisconsin, which is the dairy state. They produce loads of dairy products in the USA. And they found that they were doing their usual dreadful farming business of castrating their bullocks. And they found that these bullocks suddenly started bleeding. And the farmers who were struggling with the economic times in the early 20th century were losing lots of cows because they were bleeding to death. They couldn't work out what was going on. It had been a particularly bad winter, a bit like what we've had now, very wet, and the hay was all rotting. Now, I wonder if any of you have always thought, oh, I really love the smell of fresh cut hay. Doesn't it smell sweet? It smells sweet. Well, it's not the hay, it's the clover that smells sweet. And the product that smells sweet in the hay is coumarin in the clover. Now, coumarin isn't necessarily a problem in itself, but once it gets acted on by fungus, it gets converted to something called dicoumarol, which is warfarin. Warfarin so called because it was invented by the people of Wisconsin Alumni Research Foundation, coumarin, warfarin. That's where the name comes from. So that's how warfarin came about. And to begin with, they just used it as rat poison. It's splendid rat poison, it makes the rats bleed to death, although we've got even better poisons nowadays. So that's how it was used to start with, and then what happened was a sort of serendipitous finding was that there was a conscript to the US Army who didn't want to go there. So he decided to try and kill himself with some of this rat poison. And they discovered that giving him vitamin K, he took 500 milligrams of warfarin, which is quite a stonking dose. Normally you'd be on about 1 to 10 milligrams, so you get a massive dose. And they discovered that giving him vitamin K reversed the effects of the warfarin. So then they started understanding that we might be able to use this drug in an on-off way to control bleeding and clotting. And in fact, President Eisenhower was one of the first people to be given warfarin following a heart attack. Nowadays we've got rather better treatments for heart attacks than warfarin, but it is effective. So this has moved on a great deal. Warfarin was the only anticoagulant drug that we had, and aspirin was the main antiplatelet drug that we had. But nowadays, and this is the bewildering array of science that has happened, we have aspirin with knobs on down the line. It gets better and better, more and more potent attacks on platelets. And we have warfarin, but we also have new generation anticoagulants which don't require quite as many blood tests and are much easier to take. They're not a complete substitute for warfarin, but they are very useful in day-to-day practice, and more of you will see your friends and family on them. Ultimately, we're looking at processes which control the platelet function and the clotting system so we can prevent that all-important clot. So that's why I became a haematologist. It's because this is real science. This is real science, and this is really changing the lives of patients. So the other side of the coin from clotting is bleeding. Now many of you, I don't know if any of you have heard of haemophilia. Well, one of the most famous haemophilia carriers of all time is Queen Victoria. Now you might think, well, Queen Victoria, she lived a very long time. It can't possibly be a problem if she had haemophilia. Well, she didn't actually have haemophilia. She was a carrier for haemophilia. So women have 2 X chromosomes. Men have an X chromosome and a Y chromosome. The gene which controls the production of a clotting factor called factor 8 is on the X chromosome. Now if that gene is faulty, if it's just not there or damaged in some way, then you don't make this clotting factor called factor 8. That's not necessarily a problem for women because they might have a faulty one, but they've also got a good one. So they will make factor 8. But the poor boys have only got that one they're relying on, so the boys get affected with haemophilia. And Victoria's 8th child, Leopold, ended up very badly crippled and died of a brain hemorrhage at the age of 31. And in fact, haemophilia has shaped much of history because, of course, Queen Victoria went on to produce children that populated the royal thrones across Europe. And Tsar Nicholas was married to Alexandra, who was the granddaughter of Queen Victoria and was also a haemophilia carrier. And their eldest son, Alexei, was affected with haemophilia. So it's their oldest son, the key, who should have been the next key person, the next Tsar. And Alexei suffered so much when he was a little child that they had to get someone to look after him. And they had a monk called Rasputin, who was marvellous at hypnotherapy, which Alexei needed to control the pain from his muscles and joints. So Rasputin became very influential. Tsar Nicholas and Alexandra took their eye off the ball, and the next thing you know was the Russian Revolution. So, it's a key part of history. And in fact, it goes back even more than that. If you look in the Jewish rabbinical writings, there's something called the Talmud. I don't know if there's any Jewish people here. There's something called the Talmud, and there's some writings from the 2nd century AD which say that if 2 boys in the family have bled to death after circumcision, then you don't have to have the others circumcised.
Oh, good.
Oh, good. Got to get 2 first. Right, so they recognised even back then that haemophilia was a problem. Now, haemophilia without treatment is a dreadful, crippling disease, as we've described, and this is what the young men used to look like. Absolutely destroyed joints. And I saw a young man from India recently where they don't have access to treatment, and, you know, horrifying to see compared to what we can do nowadays in this country. Because this is what our haemophiliac boys look like these days. They, thanks to scientific advances, have regular injections of genetically engineered recombinant factor VIII, which means that by and large they lead a normal life. Now, okay, rugby is a bit of a nightmare, and I don't know why they are all magnetically attracted to rugby when they've got a bleeding disorder, but it seems to be that way, doesn't it, Jackie? But by and large, they can lead a normal life and do normal things, and they just have to be much more careful about looking after themselves on a day-to-day basis. Get the basics right, brush your teeth so you don't get bleeding gums, all those sorts of things. So all of this has come about because of a wealth of scientific research. And in fact, even now, this hospital has contributed 3 people to 10 people in the UK who have been in a trial to try gene therapy. This is a world first, gene therapy to change the course of haemophilia B and cure them ultimately of their disease. So there's a great deal going on. Now, in 2006, the NHS had the foresight to set up something called the National Institute for Health and Research. This is part of the NHS, and this is about saying that we need research. Research is key to taking the health of the nation forward. And we don't just need small numbers of people involved in research, we need everybody involved in research. We need to be learning, we need to be systematically learning from you every time you come into hospital so that we can improve care for the next generation of patients. And hence they've come up with this logo, it's okay to ask. If you come into hospital, it's okay to ask if there are any clinical trial opportunities open to you, because we want to learn more. And one of my remits within my job is to make sure that our research opportunities are maximised not only here, but across the whole south of England. Now, I had a very cosy, comfortable job down the road at Salisbury. I never planned to leave, but I was tempted because we're very lucky. Hampshire Hospitals is a visionary trust. It has a superb vision of how the future might look by encouraging hospitals not to stick knives in each other, but to work together, cooperate together to make sure that we deliver excellent care in a specialist environment where we need to, but locally, wherever possible. And that's why I came here, to be part of that vision. And that's what our Southern Haemophilia Network is all about. It's about delivering excellence in basic NHS care across the south of England. And we're being nationally recognised for that already, which just feels great. So I just wanted to tell you a couple of stories to end with. So apart from the gene therapy, sometimes the changes you make are subtle to people's lives. And this is a story of a 43-year-old dad who was born with severe haemophilia A. Now, he was born in an era where we had started to learn how to treat haemophilia A, but we were using plasma to treat haemophilia A, and we were using plasma which was derived from US donors. Now, US donors are paid to donate, and you might guess that you don't necessarily get the right sort of donors when you have that system. And there were a lot of convicts and drug addicts that ended up contributing to the pool of plasma, and we therefore ended up with a generation of haemophiliacs who've been affected with HIV, hepatitis B and C, through no fault of their own, but because the plasma products they were given to treat their haemophilia worked, but gave them these infections. And that's why we've moved on to these new genetically engineered products now. But this poor man, he wasn't crippled with his joints initially because we could treat him with the plasma, but he ended up with these infections. And he became very demoralised and really struggling to deal with his life on a day-to-day basis. He really needed to be injecting himself every other day, possibly even every day, to stop bleeding into joints, because he suffered so much damage along the way and he had these other problems as well. But he just couldn't face it. He just couldn't do it. He was too demoralised by the whole thing. And I saw him when he'd suffered 15 bleeds into his joints in 3 months. 15 times. And he was struggling. This is a 43-year-old man who was like an 80-year-old man, really struggling to walk 100 yards down the road. Now, we had a trial of a new long-acting factor VIII product, which meant that, yeah, he would need to inject himself, but he would only need to do it once a week. So he went into this trial, and it has literally turned his life around. He came bouncing back into clinic, saying he walks up to an hour a day, he doesn't need any painkillers, he hasn't had any bleeds in 3 months, and he can play with his kids. This story tells how this hospital is leading the way. This 70-year-old policeman was admitted to Portsmouth Hospital with a heart attack. And he was correctly treated with all the blood thinning treatment. But something went wrong. He had a very bad reaction. And they dissolved the clots, but then he just started bleeding. Bleeding, bleeding, and bleeding. He bled into his arm, he bled into his back, he bled into his legs, he was peeing out blood, he bled into his eyes, and he went deep orange. Catastrophic reaction. They were struggling to know how to treat him. And they phoned us up, and luckily we had established an international study looking in particular at this problem. And so we said, can you ship him up here, and let's see what we can do for him. So, the picture hasn't come out. Ah, shame. This man was one gigantic bruise. I haven't got the picture, but there you go. Sorry about that. And what had happened was, as a consequence of the blood thinning medication, he had developed a very unusual antibody against his own clotting system. So he was making factor VIII, but his body was destroying it. Now his chance of dying was over 50%. And the day I saw him, I was pretty sure he was going to die. But we were part of this big multinational study which was looking at using pig-derived, genetically engineered recombinant factor VIII to treat this problem. And so the whole team mobilised. The nurses came in through the night, the consultants came in twice a day through the weekend, and we got this guy going on this new pig factor VIII. Oh, and his picture hasn't come out again, and he didn't mind me showing you. That was a picture of him with his wife standing outside in front of the trees. 6 days later, this man. That was it. That was the bruise. That was a bit better. That's him. Going home from hospital. So that was an example of where Portsmouth didn't have the expertise to do this. We did. But they knew to talk to us. They knew we weren't going to turn around and say, you don't know what you're doing. We're going to turn around and say, we can help you. Bring your man here. Come here. We'll sort it out. And now we've shipped him back to Portsmouth. He's out in the community enjoying life, having great fun, but going to outpatients appointments there for his follow-up because they can deal with it with our support further down the line. So thank you for today. The key message I want to give you is that the NHS really is better than it's ever been. I hope you've learned a little bit about blood. Apologies that I kept it quite basic because I wasn't sure how much knowledge you'd all have. If you can take a few messages home and share them with your friends and your family, that would be wonderful. Thank you very much.